Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
If I remember correctly, your brother is into guitar.
Yeah, I know. Growing up, my dad assigned me the piano and my brother the guitar, so he was always cooler than me. And then when I was in middle school, I played percussion, and then percussion I just morphed into. I did that all through middle school, high school, and then got the drum set in middle school. So this thing is like well over 20 years old. This is the first and only drum set I've ever owned. Last time I really played it was like in med school. I was in like a band in med school. And we would just play like just sort of like on campus events.
That's awesome.
So, it's been a while since I played, but, it's been, I've been lunching around all over the country. So it'll be coming with us when we move as well. So my son really likes to just pick up the sticks and play random, he's not even 2. So he just hits everything, but he gets a kick out of it. So, probably it'll be, against my wife's better judgment, it'll be around for a while longer.
Well, I'll get us going, I guess. Friends, we have another guest episode coming right at you. Actually, kind of shocking that we have 3 guests already, Mike. And drum roll, we have Alex's brother, Austin, with us today. Austin, can you tell us how you're doing and where you're coming from today?
Hi, yes, I'm Austin Razai. I'm coming from Texas. I live a few hours down the road from Alec, and I'm primarily a primary care doctor, but I'll be moving jobs in the next couple months, and I'll be doing some inpatient and outpatient again. So excited to get back into that, but really excited to join you guys and present a case to you all, and really enjoying the podcast so far. So thanks so much for inviting me.
Thanks so much for being here. We were just talking about Wonderwall, so I'm ready for some wonder. The terrible transition.
Oh man, I think now we're gonna have to run the clips on our various instrumental journeys that we've had leading up to this moment. In summary, listeners, we're all very rusty musicians. Is that's TLDR of our intro conversation.
That'll be postscript. We'll put it at the end.
But Austin, what do you have for us today?
All right. Yeah. So this is going to be the story of a patient that I encountered in the resident clinic. And in total, it'll be 6 aliquots, and then the 7th aliquot will reveal the diagnosis. But to start off, so this is a 75-year-old woman. She's coming to the clinic to establish care, so she's never been seen in our clinic before. And she's coming today because she's had progressive left leg pain and then worsening functional status. So to give you some more information, she said that over the last several months, she's just had escalating pain in her left hip and pelvis, describing it as if she's been punched, like whenever she lays down. She's also noticed some numbness in the sole of her left foot, as well as severe fatigue and some dyspnea with pretty minimal exertion. She had become nearly wheelchair bound, requiring help with most of her ADLs, and could only walk a few steps with a walker. Her daughter, who's with her at the appointment, reported that she'd been declining gradually over since a hospitalization several months ago. And then prior to that, she was fully functionally independent, living independently, doing everything on her own, helping to take care of her husband. So this is a pretty dramatic decline. And then she hasn't seen a primary care doctor for more than 10 years. Otherwise, on her review of systems, over the last few weeks, she's not had any fevers, night sweats, weight loss, no travel, no trauma, no change in her bowel or bladder habits, and there's been no rashes. So I'll stop there.
Mike, I feel like I'm getting flashbacks to presenting you a painful red leg case I'm thinking of the 4 frames you gave us for that approach: unilateral versus bilateral, acute versus chronic, and then really what one of those was kind of focality in the leg, but plus something else like systemic. And it is kind of curious that Austin has given us a patient not just with progressive leg pain, but accompanied by dyspnea on exertion. So it's very hard to disconnect those two when a patient's been so well before. So I think just pushing the brakes a little bit on that hypothesis and making sure that those two things really are related before kind of committing yourself down that path is important. So just want to make sure this isn't someone who hasn't been like smoking a lot, and this is all just incidentals like worsening COPD. Of course, we don't have any PFTs. Just thinking about common things that could make someone's kind of breathing and functional status decline, and just be completely coincidental with what we're seeing in terms of more of this like mechanical, painful reason for falling. And I think the other important part of the picture to sort of dissect in terms of a physical exam on the patients is what is it on the exam that's preventing the patient from walking now? It sounds like certainly there's a very strong pain component to the hip. It sounds like a pretty deep pain, which my mind automatically jumps to really deep structures in the hip, like what's going on inside of the joint space. Well, an X-ray reveals some sort of chronic, osteoarthritic changes or osteonecrosis there. That word is just kind of now presenting itself, but really like beyond the joint itself. What about like the bones around the joints? If it really is this deep pain, what's going on in the pelvis with that X-ray? Are we seeing any sort of like lytic lesion in the bone? That would be explanatory for that. So that's all very interesting. But then Austin gives us this extra information that there's kind of the sensory issue going on in but you said it was the plantar surface of the foot, Austin, like the bottom of the foot. Is that right? Got it. Okay. So I don't know, Mike. I think that really adds another interesting dimension to this, because when I think, okay, something's going on potentially deep in the bone or the joint, connecting that with kind of nerve symptoms, I have a hard time doing that off the bats. I can think about that a little bit more, and I'll just pass it off to you for kind of your initial reflections.
I think the first thing I'll say, because you said most of my thoughts already, is it's very hard sometimes to tease out why is someone who was functional a few months ago now in a wheelchair, and even the dyspnea on exertion versus issues of strength. I find that people will describe deconditioning in so many different ways. Some people describe it as a lack of strength, but there are those who they feel sort of almost winded, but what they're really feeling is a lack of strength. And so that can be challenging to tease out sometimes. And I find oftentimes getting collateral and observing them actually walking is part of, does there seem to be a respiratory component to this, or is it just that they feel so wiped out that they're describing that fatigue and that weakness as also maybe some shortness of breath because there's an exertional component to it. So that's just, that's always been challenging for me. And the other thing is exactly what you said, that once you add in sensory changes on the ipsilateral side, it's harder to blame just bone and tissue. And you start to think about something that is again, compressing nerves, and, the lower spine. I certainly can do this. Or do you have some sort of compressive process in the bone or tissue that's pressing on some sort of nerve? But to have something in the, she's describing it as a pain in the hip and the pelvis. So to have something that proximal and to have a sensory loss so distal, it can't be like a small little nerve fiber. It needs to be something that's, going to travel down into the bottom of the foot. So I agree that probably some amount of, imaging as well as just neurologic exam here. I think it's reassuring that there's no bowel or bladder changes, right? Of course. And then the last thing, and I may have missed this out, Austin, this hospitalization a few months ago, the details of that, if we know them. I know it's not always available to us in our wonderful EMRs.
There could be no better transition to the next aliquot. So here we go. So yeah, 6 months earlier, she had been hospitalized at a neighboring hospital for acute respiratory failure, which they thought was from community-acquired pneumonia. And this was unfortunately complicated by renal failure that required dialysis. Imaging at that time showed a left lower lobe consolidation, a left pleural effusion, and multiple osseous lesions of the spine and pelvis, though these were not pursued further diagnostically. They did do a thoracentesis, and pleural analysis showed an exudate. It was unknown if cytology or cultures were sent just based off of available records. But they did do a kidney biopsy at that time, and it showed severe diabetic and hypertensive nephropathy with 70% fibrosis. So a little bit more about her past medical history. So she has end-stage kidney disease. Unfortunately, she did not have renal recovery, so she's currently on hemodialysis 3 times weekly. She has hypertension, type 2 diabetes, iron deficiency, anemia, GERD, COPD, and known osteoarthritis of her knees. Known prior surgeries. There's no known family history. Socially, she's from Mexico, but has been in the United States for many years. She lives with her husband, but as alluded to before, her daughter now kind of helps take care of her most of the day. She just sort of stays alone at night. For health-related behaviors, no alcohol or substance use. She does use tobacco and continues to do so and has greater than a 50-pack year history of smoking. Medications, she's on EPO with her dialysis, sevelamer, losartan, nifedipine, some iron, pantoprazole, a inhaler for her COPD, and then some analgesics, which include some Tylenol number 3 and some tramadol. That's the end of this aliquot.
Mike, you want to start with this one?
Yeah. So we have a very different picture, right, of who this patient is, and this question of why would someone who is so functional now have so much progression in terms of functional loss, right? I think just globally, right, doesn't mean that we know what's going on, but it tells us this is a person who's become very sick in the last 6 months, and probably also was sicker than they looked in the years before that, right? With some of the renal findings, the COPD. So there's been some chronic disease on top of, and even though there was good functional status for what sounds like a long time, which was good. So that's just something to keep in mind. It is hard to ignore the numerous osseous lesions, exudative effusion, her age, and the fact that she has a really significant smoking history, right? So all of those things together would be concerning for any kind of malignancy, right? With mets to the bone, and progression of those mets or new mets, you can imagine, could definitely cause hip girdle pain, right? And of course could be compressive on some sort of nerve root or worse in the spine. It's helpful to know that there was we have a kidney biopsy, and so we don't see myeloma in the kidney, at least, as the cause of her progression to ESRD. But also possibility. But I do wonder if hiding in that left lower lobe consolidation and pleural effusion, if maybe there's a primary lung cancer. So I'd probably, in addition to getting the scan of the spine, which I think I'd still do, probably would CT her. She also is having pulmonary findings, but I'd be worried about those things.
Yeah, my thoughts are completely in line with yours, Mike. And I think the possibilities were very vast in terms of the permutations available on aliquot number 1. But I think that having this really beautiful picture of the patient now helps us to kind of like disconnect that some of these things could be related. Like, okay, we know she has COPD. We know she was hospitalized for pneumonia. So suddenly the dyspnea is less interesting in terms of a connection to what she's coming to today for the clinic, which is the hip pain. I feel like that's really our problem to solve. I'll just say that bone pain can be very, very severe to the point where you can't weight bear anymore on it, and that's often really the presenting symptom of a metastasis to the bone. So now knowing that there's multifocal kind of osseous lesions, I completely agree with Mike that basically it's a tissue issue at this point. And yeah, I like the idea of the kind of lung cancer investigation, endobronchial lesion leading to like post-obstructive pneumonia, totally a thing, often the first presenting sign of cancer, often recurrence. But it sounds like very initial interactions overall in this patient's life with the healthcare system. So knowing about colonoscopy history will be important too. Sounds like no mammograms available. And I guess my only final question about the past hospitalization, Austin, is to end up on dialysis. I'm guessing, based off of the kidney biopsy, that this was she was already kind of on the edge with what we were seeing on the biopsy in terms of her renal function of kind of hitting dialysis, and it was a very minor hit that led her there. But just wondering if there was any kind of interesting data on her renal workup at that time, like any hydronephrosis, anything like that. But expecting the answer to that is no. It sounds like she was just very predisposed. And I think we could just move forward with that.
Yeah, great question. We didn't have these in real time. I had to get these records from the neighboring hospital after we saw the patient for the first time. But from what I could recall, there really wasn't anything of concern. Just as you said, I think most likely this patient had chronic kidney disease as evidenced by the biopsy, and then just had a hit of likely ATN in the setting of their severe presentation, and then just unfortunately kicked them over the edge to go on to become dialysis dependent. Yeah. Okay, so moving on to the next aliquot, number 3. So vital signs, she was afebrile, blood pressure was 150/60, heart rate was 85, respiratory rate 16, and then she was satting 98% on room air and had a BMI of 29. On exam, generally, she was fatigued appearing, she was sitting in a wheelchair, cardiovascular, normal rate and rhythm, there's no murmurs, there was no edema. Pulmonary, there's normal effort. Her lungs were clear to auscultation. And then sort of musculoskeletal neuro exam, there was pain to palpation of the left hip, but there was no swelling, warmth, or redness. There was intact range of motion as well. The strength in the lower extremities was 4 out of 5 bilaterally, but there was no overt sensory deficits that we could pick up on to fine touch. The reflexes were 1+ and symmetric. And then we attempted to get her up and to ambulate her, but it was just too painful for her to weight bear. And that was the extent of the exam that we had. So her labs, she had a CBC with a white count of 9.6 normal differential. Hemoglobin was 11.1 and platelets were 299. Her metabolic panel was consistent with being on dialysis. The calcium was 8.5. Her liver test showed an AST of 75, ALT of 42, an alkaline phosphatase of 270, total protein of 8, albumin of 3.2. And then just to round things out, she had some iron studies that showed a ferritin of 588 and a transferrin saturation of 13%. And that's the end of this aliquot.
Okay. Why don't you take this one, Andrew?
Yeah.
You're a big fan of elevated alk phos. That's it.
This one isn't as high as our osteomalacia case, but I do believe that this is technically an elevated alkaline phosphatase. No, I mean, we already know this patient has bone disease of unclear etiology, so not a surprising finding. It sounds like mostly isolated alkaline phosphatase elevation. So this isn't someone like I'd be setting like a GGT on or anything like that, because I think we kind of have our answer already. The only exception to that rule would be if there's any concern for like new liver disease, which I honestly wouldn't be super surprised if she had some metastatic liver disease, just given we know that what is going on is everywhere. I keep saying cancer, but this could technically be something else. I hear anemia. I hear that the ferritin is mild to moderately elevated. It's a non-specific inflammatory marker, which in that degree of range could suggest that there's some kind of anemia of inflammation going on. But when you have a patient with they're coming in with renal failure, which we've already kind of commented that the diabetes was certainly at play. Did we miss some myeloma cast nephropathy or something else? Mike talked about this earlier. I'd be curious because the protein gap, Austin gave us a protein of 8 minus an albumin of 3.1 is a 4.9, which is an elevated protein gap, which, you can have elevated protein gap from basically your albumin's very, very low. So that's kind of almost a fake protein gap in my head. But this patient's albumin is really only mildly decreased. And I think the total protein is a little bit high. So then the question really becomes, what's driving the total protein up? So is there monoclonal protein that's driving that up, such as that would come from something like a plasma cell dyscrasia, and particularly myeloma, or is this polyclonal hypergamma-globulinemia? It's basically a lot of different diverse types of antibodies being produced that would lead to a total elevated protein. Really, just to summarize that, the former is cancer, plasma cell dyscrasia, and it's on our mind as the patient has bone lesions. And the latter is more so a response to chronic inflammatory conditions, usually some sort of autoimmune disease or infection will cause polyclonal hypergamma-globulinemia. So, if we're really on this dedicated path forward to figuring out what's the cause of the bone lesions, I do think that that's something of interest, particularly because we may be able to get a very strong clue to what's going on just with some blood work, actually, in terms of this paraprotein workup. And that may be one of the most productive ways to get at least a strong clue toward the final diagnosis, maybe not to the final diagnosis. But Mike, I'll pass it off to you. What did you think?
I actually don't know I have much I don't think I have much to add. The protein gap is sort of, I think, the thing that jumps out the most here, and hard to read into the calcium in the setting of dialysis, right? So I agree, and I think, let's take a look at what is that protein gap, right? Let's take a look at the SPEP and IFE and light chains and see what we got going on there. But I will say this is just completely unrelated. I do not think this woman has HIV, but this was a fun thing I learned on our Donaldson Infectious Disease Service, is that HIV causes a protein gap, and it does so basically because each HIV causes B cell proliferation. And so the B cells just pump out gamma globulins, and that's actually why people with HIV get B cell lymphomas, and also why it kind of causes ITP. But I remember it was like very early on in the AIDS pandemic. I wasn't alive for this, but I forget who it was, but it was one of the infectious disease doctors who's been around for a long time, who said that they saw a patient, young person, sort of the clinical picture fit, but there was no test yet for HIV. But the protein gap was something they would kind of make note of because it was an otherwise young, healthy person. They really shouldn't have a protein gap. And so it was like a marker, interestingly enough. So again, I don't think this woman has HIV, though. I think we have highly, a lot of signal here into something. And so let's just see if it's monoclonal or not. I agree with Andrew.
Yeah, I'll also give some final comments, Austin, that just kind of came to mind before this next aliquot, because, how to get suspicion for myeloma. I'm now thinking you gave us like a calcium level earlier. This is something we learned at CP Solvers, which I think is just brilliant. I cannot believe that this pearl has not been circulated more widely, but they teach us like crab findings for complications of myeloma, meaning calcium, hypercalcemia, R, renal insufficiency, A, anemia, and B, bone findings. Really, you want to like flip that acronym, because the foremost letters in this acronym, BARC, actually better reflects the frequency of those findings. So bone findings are actually most common in the initial kind of presentation of myeloma, followed by anemia, followed by the renal insufficiency, followed by the calcium. So the fact that we didn't see a high calcium here doesn't necessarily point us away from that diagnosis. I always love that pearl, and I believe Reza is the one who's widely circulated that. Reza, if you're listening, thank you. Love that pearl.
Yeah, no, excellent thoughts, great teaching. And yeah, so the kind of second round of labs that we have that we got, so we got a vitamin D and it was low at 9. The PTH was 427. Got a SPEP and a UPEP, and there was no monoclonal spike that was noted. She had serum-free light chains, which were both elevated, but the ratio was normal. And then HIV and viral hepatitis testing was all negative. As requested earlier, she got a CT chest, abdomen, and pelvis with contrast, and it showed multiple osseous lytic lesions throughout the thoracic spine and pelvis. There was no pulmonary nodules or mediastinal disease. There was bilateral enhancing adrenal nodules up to 4 centimeters in size, and then there's rectosigmoid wall thickening. Otherwise, there were no other significant findings. And then she didn't report any GI, GU, or breast symptoms, but as part of sort of healthcare maintenance, the resident had ordered kind of routine cancer screenings. And while we were waiting for those, an MRI of her pelvis and her lumbar spine, you guys were requested, was also done for her ongoing symptoms. And we'll reveal the findings of that in the next aliquot. And then I have just some like stills of the CT if you want to see them. I wouldn't say there's anything like too interesting about them, but if you'd like to see them, I'm happy to show them to you.
That'd be awesome. I think you have a button to share, Austin. Let me know if you need perms or anything like that.
And Austin, I want to make sure you said there were no primary lung findings?
Correct.
Yeah. Okay.
And then let me see if I can blow that up.
Perfect. While you're doing that, Austin, earlier you gave the iron and transferrin. Were those other ones low? Like, did she have iron? Some signs of iron defificiency on top of the?
She has known iron deficiency anemia. The etiology was not elucidated at that point, but she has known iron deficiency, and so to your point, like had signs of chronic inflammation, but a T-stat low enough to be consistent with iron deficiency, at least a component of that.
Okay, so some mixed. Got it. Okay.
So yeah, so we have a sagittal view, which you guys can see. I don't know if you, basically I'll just point out here, there's what looks like an old compression fracture, and then there's some sort of hyperintensities or hyperdensities that you can see in some of the spine, the vertebrae, and so those will be consistent with the Mets. And then here's the other cut that I had.
Is her kidney dislocated? What if or that's bowel and kidney?
That's bowel, yeah.
That's bowel.
Yeah, we're pretty posterior.
Like her kidney looked transected to me.
You can see here, you can see that she has a pretty significant pelvic lesion there. Mm.
And rectosigmoid.
Yeah, great images.
You said, and they're bilateral adrenal nodules?
Correct, bilateral adrenal nodules.
Okay.
So just to summarize, we were seeing just all these osseous lesions. We're seeing the pelvic lesion, that is the culprit lesion for why she can't weight bear anymore. And then the labs were no monoclonal protein, an expected light chain ratio for CKD/ESKD. I'll just say before I pass it off to Mike, there's such thing as non-secretory myeloma, where plasma cells are just inside of the bone. They're just not secreting all the light chains that kind of cause the complications we see, most scarily in the form of renal failure. So it doesn't rule that hypothesis out. But I think I'll just pass it to you, Mike. I think all that to say, I think myeloma is still on the table, but we know that this patient has risk factors for cancer otherwise, and we really just need tissue at this point to kind of make a final determination.
Agreed. And I want to make sure I didn't hallucinate, but rectosigmoid thickening on the CT abdomen pelvis, correct?
Correct.
with bilateral adrenal nodules. So I think known iron deficiency anemia with a lack of outpatient primary care and cancer screenings. She's the right age. That's I think that's where I'd go first, probably, as a colonoscopy, endoscopy, and see if there's something there that's obvious, and getting tissue on that. I agree. I think that's probably the next step for her.
Okay, very good. So next, I alluded to it before, but we ended up getting an MRI of her pelvis and her lumbar spine, and it showed just a heterogeneous marrow signal suggesting infiltration, which was felt to be most suspicious for metastatic disease, as you guys have been right on top of. And then it showed a T11 compression fracture, which we saw on the CT scan, and then a left pubic ramus pathologic fracture, which we also saw on the CT scan there. And so actually what we did was we ordered a bone biopsy to help arrive at the diagnosis. And so I'll just pause there for any reflections. And then the next aliquot will be the last piece of information before we get to the final diagnosis.
Yeah, I got nothing to say except I agree with Mike's thoughts that looking concurrently at the rectum is probably a good idea with the soft tissue findings. Mike, this is our third case in the month. This is another case in the past month where we really need tissue. So I don't have too much else to say.
Agreed. I'll say that I'm surprised. I was not expecting to find Mets in the marrow. They don't have a pancytopenia. Their platelets are normal. So I'm surprised by that. I feel like I'm thinking GI, but I feel like there's always a twist with these cases. So interested to see what we find out.
Okay, yeah. So next piece of information here. So while we were awaiting, so she got the bone biopsy done. While we were awaiting the results of that, as part of her initial screening, she got a mammogram done, and it showed that she had a 1.8 centimeter retroareolar spiculated mass with nipple inversion on the right, and a 6 millimeter spiculated mass in the left breast, as well as abnormal right axillary lymph node on ultrasound, which an ultrasound, along with the mammogram, was done and confirmed the masses and vascularity, which they commented on in total as BI-RADS 4. And so biopsies were recommended and obtained. And so the next aliquot will reveal the diagnosis.
My only reflection is if there was a hemonc discussing this case, I think they would have arrived to it's what sounds like potentially could be actually breast cancer. She could have two processes going on, of course, too. Like, we don't know. She doesn't have colonoscopy on file. She has some signs of iron deficiency, so she could have something going on there. But does she have breast lesions? And why would that not be surprising to a hematologist, oncologist who studies how these things spread? The patients I've had with colon cancer that spread often go to the liver quite substantially. So if it's really all over the body, I feel like we would be hearing more about kind of incidental findings of a lot of liver lesions, more bilirubin and alk phos elevation than we're seeing, because it really is sounds like a very bone-centric disease that we're kind of not seeing elsewhere. And not a hemonc, but I believe that sounds potentially more in line with a breast cancer hypothesis. So, Mike, I'm just wondering if that was the early clue for this case.
I agree. I think she has at least breast cancer. And the question will be, does she also have, non-secretory myeloma or some sort of GI pathology? But it's really hard to ignore those findings. If we had gotten imaging in reverse, had she come to you with, mammography already done, right, with all the other stuff we knew, would we have, you know what I mean? Like, if we reverse the order in which we got these tests back, I think we probably would have said, this is metastatic breast cancer. So the fact that we're getting them in this order, I don't necessarily know that it should change the way we think about it. I agree with you that I think it's at least breast cancer. And also definitely point taken that bones without any liver involvement would be unusual for a primary GI malignancy.
Yeah, I feel like Austin kind of has fed us these little kind of divergent paths. First was the protein gap. Next was the colorectal soft tissue thickening. Next is the spiculated breast mass. I don't know. Also, you're going to tell us this patient has glioblastoma. What does this patient have?
Yeah, no. So the final aliquot here. So yeah, we got the bone biopsy done, and it showed no growth of any organisms, or the stains were negative, and it showed metastatic adenocarcinoma. And then we got the breast biopsies done as well, and it showed invasive adenocarcinoma with ductal and lobular features, ER and PR positive and HER2 negative. So the patient was diagnosed with metastatic ER, PR positive, HER2 negative breast cancer. She established with oncology, got started on palbociclib, which is a cyclin-dependent kinase inhibitor, and anastrozole, and then some zoledronic acid to try to stabilize her bone situation. And palliative care was consulted, just given the state of everything going on. And despite therapy, unfortunately, she progressed with her frailty and pain and died a few months later. So I wanted to give you guys time to reflect before I share my reflections and why I wanted to share this particular case with you all.
I feel like I've sort of started, I guess, with my reflections right before that last aliquot, in that just the order in which we get results back often influences the way we think about a case, which is different than the board exam or, case presentations at Noon Report, where you're getting all the information at once and perfectly packaged. So I really appreciated the authenticity of this case in sort of getting these tests back at the actual way, the actual rate and an order that we would get them in the outpatient setting. And I agree that there's just this is a case where you just have a lot of opportunities to anchor and find your way down a path, right? I mean, I think all of us were thinking metastatic malignancy, but, mind went to the lung, then went to myeloma, but the protein gap, right? First lung with the possible post-obstructive pneumonia, exudative effusion, right? Then myeloma with the protein gap, then a primary GI malignancy with this thickening, and then MRI. So I think just a good reminder to keep things broad in terms of differential, which of course is not anything revolutionary, I'm saying, but I liked the case because it presented a lot of off ramps that ended up being dead ends.
Yeah, and I feel like I'm thinking of you teaching us last week, Mike, about for the acute red leg framework, you're not running one approach, you're running all at once, right? Similar to that in this case, we're really running all primary malignancy options up front, which we did. We said them all out loud. But even with that in mind, we're very tempted to kind of follow those little breadcrumbs that we perceive. And I know Zavin listens to the podcast. As he said in one of his Grand Rounds talks, you need to play medicine more like poker and not like chess. Like, we think we're very smart in some of these situations where we kind of perceive these clues, but you could really fall on your face if you're not kind of keeping your options open, like you're saying, Mike. But I'm left with a big question. We had the CT chest. We missed the BIRADS for breast malignancy. So I think, Austin, you probably have some teaching about kind of what happened there. And I'm very curious to hear what headspace you were in with this patient and what you got for us in terms of teaching.
Yeah, amazing discussion. And you really followed like kind of everything that we were thinking about in real life, and the fell through for some of the same things that we did. I think you guys were more elegant than we were, for sure. So basically, when I was presented this patient, first of all, I was just stunned and devastated that this patient had gone 6 months knowing that they had diffuse bone lesions and nothing had been done. And I think if we understood how this patient accessed care before, that it was a real disservice for the patient to be discharged from the hospital without really trying to understand the nature of this patient's disease. And so that was just devastating in and of itself. It then took weeks and months. It took us about 2 to 3 months for us to get to the final diagnosis of breast cancer, just logistically with getting all the tests done and everything like that. So how we approached this was like, hey, oh my gosh, this is really devastating. This patient's having like terrible functional impairment, but there's also like, everything is on fire. Every organ is down in some way, shape, or form. Like, what do we need to do now? It's like, hey, we're concerned this patient has malignancy, just as you were. It's been 6 months. Let's re-image. So we got the I just said pan scan her. We got the CT chest, abdomen, pelvis, and then there was signal all over the place. I was like, hey, the only thing that I can really pick up on to do that can unify everything is like the bone. So let's go for the bone. Which bone to pick? Bone biopsies generally are relatively low yield, but if you're going to pick a bone, don't do the spine if possible. Do like a longer bone or the pelvis. And so that's why we picked the pelvic lesion in particular to try to biopsy, knowing that it will be a potentially not give us an answer, but at least in that moment, that's something that we had to do. So I have to say, I was also thinking of myeloma, but as you guys astutely picked up on, we first of all, like non-secretory myeloma is very uncommon. So if we think back, this patient had a kidney biopsy, like right there waiting for us. And then looking back, I'm not sure if they ever got the monoclonal evaluation when she was at the other hospital, but nonetheless, like statistically speaking, like it's pretty low chance that she's going to have this kind of devastation and for us not to pick it up on the kidney if we're trying to unify everything together. It's possible, but it seemed less likely. So I rushed for those labs, but in hindsight, probably wasn't for the best. Then basically what happened was like actually I'm as a primary care doctor, I really don't like to order cancer screenings willy-nilly. I think some people think, hey, you come to the primary care doctor, the thing that we do is order cancer screenings. But, does this patient really going to benefit from cancer screenings? Routine cancer screenings? Like, absolutely not. There's absolutely not. And so I did not order them initially. But what happened was it was taking so long to get everything done. I just stepped back and say, hey, this patient has metastatic bone lesions. What's the most common cancer that does that? It's breast cancer by far. And so I ordered the mammogram. We got the mammogram done pretty quickly and boom, there it was. And so if I just simplified everything and went back to base rate entirely, breast cancer. Like, just as you said, if it was an oncologist discussing this, I'd be like, oh, this is definitely breast cancer, no question whatsoever. But we fell down the same traps that you guys did. Is it the lung? Is it the GI? We didn't have an explanation for that. Maybe it was just patient was constipated at the time. Maybe they had colon cancer that we didn't recognize. Unfortunately, the patient succumbed to their illness before then. But hard to say. But this is the challenge of the CT chest, as Andrew was alluding to before, is that the CT is what structures in the thorax are CTs not good at picking up on when you're doing an evaluation for either infection or malignancy. And the answer is breast and the heart, the internal structure of the heart in particular. And so Robbie has taught us this a couple of times. And so it really stuck with me that going back on the CT, like, I could see some changes when I looked myself. There was nothing commented on the radiology report. But when I went back in retrospect and looked, maybe there was something there, but nothing that, unless you were specifically saying, hey, I'm worried about the breast, that you had commented on. And even then, I'm not sure they'd be able to get to the diagnosis or not. So the CT is not a good test to look at the breast. And so if you're worried about the breast, you have to get dedicated imaging for the breast itself. And so that's why I really enjoyed this case, is that there was so much hecticness going on. We knew we were worried about cancer, but instead of just stepping back and saying statistically, what is the most common thing that we should do to prioritize our tests, we just went with more esoteric and less likely diagnoses first. And so I don't think that's uncommon when we're in the hospital, we're dealing with hectic things going on. Like, we want to try to get to an answer and we pursue multiple hypotheses, as you said. But I don't think oftentimes when we pursue multiple hypotheses, it's with a single test. So like a CT chest, abdomen, pelvis, man, we're going to cover a lot of things, but it was really the whole in that let us down. And probably, I did a patient a disservice by not ordering a mammogram up front the first time I met this patient. And so that was like one of the main reflections I had from taking care of this patient and learning from their case. And so I think you guys touched on everything that I was hoping for you guys to touch on. And, thanks so much for giving me the time to present it to you.
Wow. Mike, I'm floored. It's like an honor and a privilege to have people bring such eye-opening cases to us and really share it with everyone who's listening to the podcast. So no doubt people are going to listen to this episode and they're going to be able to make such easier strides for cases like this by really being grounded in the basics. So this is like a true DX atypia type of case. This is really what we kind of wanted to have on the show, these sorts of eye-opening cases. So thank you, Austin. It's very humbling to know that we all fall for these cognitive biases, no matter where we practice. So thank you for bringing this case all the way from many, many states away. And I have nothing else to say. Thank you, Austin. Again, honored and humbled to have you here.
I agree. I really appreciate the case, and just walking us through your thought process as you were ordering these tests. It's always just helpful to hear how someone else would think through the case. And I guess just two very discrete learning points that I'll take away from this is one is that solid malignancies cause a protein gap. It's polyclonal. And so just a thing to remember, because often we're getting it because we're worried about malignancy, and just because it's just because you see it's polyclonal doesn't mean they don't have any malignancy. It just doesn't mean they have monoclonal myeloma. And the other was that the MRI, I believe it said there was nipple inversion, and it occurred to me that in someone with bone lesions, an elderly woman with bone lesions, I probably should do a breast exam, and I have to be honest that I don't think that I would have. I'm just being totally honest with myself and authentic with the audience. And so I think I will do my best to do that in the future, but I primarily work with a male population. So that creates a hole in my physical exam. That was another thing I'll try to keep in mind when I see a female patient with bone mets.
Yeah. Thanks again, Austin. Really, really such a pleasure to have you here. And thanks everyone for listening. Let us know your thoughts on this case for sure.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.